Hey guys, it is Miss Smith, and today we're going to be covering congenital heart disorders. So a congenital heart disorder is an abnormality or anomaly of the heart that is present at birth. There's also acquired heart disorders, and we've talked about those, but those are abnormalities after birth that compromise the heart's function, so such as rheumatic fever. But today we're going to be talking about congenital heart disorders, so present at birth. There's many different causes. Genetics can cause it. So family history, a history of Down syndrome, Fetal syndrome, Turner syndrome, maternal medication, so lithium, thalidomide, or phenytoin, and environmental, so intrauterine rubella exposure, maternal alcoholism, diabetes, and advanced maternal age. All of those can be causes of congenital heart disorders. First, we will need to talk about fetal and postnatal circulation. So fetal circulation is a little bit different when the baby is still in the womb, when it's still a fetus. It's going to be different than our regular blood flow. So the placenta is going to be the source of oxygen and nutrients during fetal development. Oxygenated blood is brought to the fetus by the umbilical vein and enters the fetal heart via the inferior vena cava. So you can see the placenta connects to the umbilical vein, and then that travels up, brings oxygenated blood. And there's kind of two pathways that it can go. So we have the oxygenated blood. It can split off and go to the ductus venosus and kind of go through the liver and supply the liver with oxygenated blood. Or it can bypass the ductus venosus and go straight into the superior vena cava, or the inferior vena cava, and then it can travel up into the right atrium of the heart. After the blood goes into the right atrium, it can go into one of two pathways. So it can go from the right atrium to the right ventricle. So it can be pushed down, and then the right ventricle can go up into the pulmonary artery right here. Or it can bypass this right ventricle, and it can go through the foramen ovale right here. So there's an opening between the right atrium and the left atrium. So this blood the oxygenated blood coming from the inferior vena cava can go into the right atrium, bypass the right ventricle, and then go into the left atrium. And the reason that it bypasses the right ventricle is because, remember, in normal circulation, it goes right atrium, right ventricle, and then out to the pulmonary artery to the lungs. Well, when the baby is in the fetus, the lungs aren't being used, right? Because the oxygen is coming from the mother, from the placenta. So the lungs don't need that much oxygen. So in order to get more blood to the rest of the body that is developing, it can just bypass this right ventricle, which bypasses the pulmonary artery, and then it can go into it just goes from the right atrium to the left atrium through this foramen ovale. Now let's say that it does go into the right ventricle, goes into the pulmonary artery here. So a small amount of blood will go into the lungs, but it can also bypass the lungs again through this called the ductus arteriosus. So basically what that does is, instead of it going out into the pulmonary up through the pulmonary artery to the lungs, it bypasses the lungs and just goes straight into the aorta. So the pulmonary artery and the aorta are connected via the ductus arteriosus. So the blood can just join here through the aorta and then out to the rest of the body. After the baby is born, that first breath is going to cause the newborn's lungs to expand, and then the fluid that is in the lungs is going to be absorbed into the pulmonary circulation. So the pulmonary and the right-sided heart pressures are going to fall as the systemic pressures rise. So basically what happens is, this is before birth, and then this is after birth. So basically that foramen ovale that connected the right atrium and the left atrium, that closes, right? And then the ductus arteriosus up here that connected the pulmonary artery and the aorta, that also closes, and it turns into the ligamentum arteriosus. So your foramen ovale closes and your ductus arteriosus closes. And so then that causes normal circulation. I'm going to play two different videos for you guys. They're both going to explain fetal circulation and the postnatal circulation, but both of these videos are really good and they kind of build off of each other.
Finals.com. I'm going to talk about fetal circulation in this video, and to really understand fetal circulation, first you need to know some basics about postnatal circulation. So here we have a basic diagram representing postnatal circulation. So if you imagine the way that blood flows through the body, if you've got a diagram here of the lungs and here of the body, let's say blood starts in the right hand side of the heart, in the right atrium, flows to the right ventricle, then this is pumped out into the pulmonary arteries, which takes blood to the lungs. You get rid of CO2 there and you pick up oxygen there. It then comes out of the lungs through the pulmonary vein into the left atrium, left ventricle, and then out into the aorta. And from there all that oxygenated blood is taken to the body where it's used, and the blood then picks up the byproducts of respiration such as CO2. These are then taken back via the inferior and superior vena cava back into the right hand side of the heart. So essentially the objective of postnatal circulation is to take blood from the right side of the heart to the lungs, then to the left heart, then to the body, and then to return back to the right hand side of the heart. So next.
So that first part of the video was him just explaining postnatal circulation, so normal circulation, which we have already covered that. Now he's going to get into the fetal circulation.
A bit more complicated, and that's because the objective of the fetal circulation is to take blood to the placenta instead of the lungs to get rid of those waste products and to pick up oxygen and nutrients. So let's label this diagram. Okay, so you can see some key structures here, and some things that I particularly want you to pay attention to are the ductus arteriosus, the ductus venosus, and the foramen ovale. Now these represent the three fetal shunts, and they're essential to making sure that the fetal circulation works properly. Let's go through how the blood flows through the fetal circulation. So if we start with the aorta, the blood is pumped out of the heart, so you've got oxygenated blood coming out of the heart, going to the body, down this way. But a portion of that blood, once it is split into the common iliacs and then the internal iliacs, a portion of the blood comes into the umbilical arteries. And this blood flows through the umbilical arteries into the placenta. And the placenta is where the fetal blood and the maternal blood come very close together, and nutrients from the maternal blood can transfer into the fetal blood, and all the waste products from the fetal blood can transfer into the maternal blood. So once they've been through the placenta and all that good stuff has happened, the blood flows out of the placenta through the umbilical vein. Now the umbilical vein is connected to a shunt. So this is lovely oxygenated blood coming out of the umbilical vein. Now 20 to 30% of that blood goes through a shunt called the ductus venosus, which is here. And 20 to 30% of that blood joins the inferior vena cava directly. So all that lovely oxygenated blood goes straight up the inferior vena cava into the right side of the heart. Now the 70 to 80% of the rest of the blood joins with the portal vein going into the liver, and then once it's been through the liver, it comes out of the hepatic vein and also joins the inferior vena cava. So you've got all that lovely oxygenated blood coming into the inferior vena cava, into the right-hand side of the heart. Now this is where we meet our second shunt, and this is called the foramen ovale. So what this is difficult to see on this diagram, but what essentially this hole does is it's a hole in the wall, the septum between the two atrium, or the two atria. So it allows blood to flow from the right atria, bypassing the lungs, bypassing the the right ventricle, straight through into the left atrium, where it can go into the left ventricle and out to the rest of the body. Okay, so the foramen ovale allows oxygenated blood to bypass the lungs. Now, not all the blood goes via the foramen ovale. Some of it goes via the right ventricle into the pulmonary artery, or the pulmonary trunk here. Now, this is where we come across our third shunt, which is called the ductus arteriosus. Okay, now this is a connection between the pulmonary trunk and pulmonary arteries and the aorta, which means that once again, blood can bypass the lungs and go straight from the right ventricle into the pulmonary trunk, into the aorta, and down to the rest of the body. So here we have two ways, the ductus arteriosus and the foramen ovale, for blood to bypass the lungs in the heart, because we don't need circulation going to the lungs. The lungs aren't really doing much in the fetus. Now, these shunts are aided by the fact that in the fetus, the pulmonary vascular resistance is very high. And this is because the alveoli are all closed and everything in the lungs is sort of squeezed. So flow is always going to prefer the path of least resistance. So instead of going into the pulmonary arteries, it flows into the aorta. But what happens at birth is the baby takes its first breath, and this causes all the alveoli in the lungs to expand, decreasing the vascular resistance in the pulmonary vessels. There's also a drop in the circulating prostaglandins in a response to the increased oxygenation of the blood from taking that first breath.
This is the second video I will show you guys, and it's just a little bit different. Maybe if that one didn't make so much sense to you, this one is drawn a little bit different.
Hello, in this video we're going to talk about fetal circulation. The fetus is you when you were inside your mother's womb, the uterus. Now, the fetal circulation is actually very complicated and different to the circulation of a baby, which is essentially the circulation of an adult. In this video, it is assumed that the viewer, you, will already have some understanding of normal adult human circulation. So if you don't, please revise that. Now let us focus on fetal circulation. Here is a fetus and its lungs and heart. Let's zoom in and focus on the heart. The heart has 4 chambers. The right consists of the right atrium and right ventricle. The right side of the heart is responsible to pump blood into the lungs. Blood returns to the heart, to the right side, via veins, here in blue, and will enter the right atrium and then the right ventricle before being pumped by the heart into the lungs. However, in the fetal circulation, there's actually an anatomical opening, a hole, called the foramen ovale, which is the connection between the right atrium and the left atrium. And so when the blood flows from the right atrium to the right ventricle, blood will also flow from the right atrium to the left atrium. The left side of the heart, it consists of the left atrium and left ventricle. The left side of the heart is responsible for pumping blood to the rest of the fetal body. Aside for the anatomical hole, the patent foramen ovale, there is another important connection, or sort of hole, called the patent ductus arteriosus. The patent ductus arteriosus is the connection between the pulmonary artery and the aorta. And so in the fetal circulation, blood traveling through the pulmonary artery can bypass the lungs and go straight to the aorta and be then transported to the rest of the fetal tissue. The blood can bypass the lungs because there is a lot of pressure in the fetal lungs. And so blood can actually easily go into the aorta. The patent foramen ovale and patent ductus arteriosus allow a right to left shunt, which means blood normally entering the right side of the heart can easily be shunted to the left side of the heart, bypassing the lungs. In fetal circulation, there is really no need for blood to go into the lungs because the fetus is not breathing air anyway. Rather, the fetus relies on the oxygen delivered by the maternal circulation in the placenta. See, the placenta is this important connection between the mother and the fetus. The placenta delivers oxygen and nutrients to the growing fetus via the umbilical cord. The umbilical cord attaches the fetus to the placenta. The umbilical cord is not just a cord, it actually contains veins and arteries. The umbilical vein, here drawn in red, travels from the placenta to the fetal liver. There is one umbilical vein, and it is drawn here in red because it is oxygenated. It contains oxygenated blood which was delivered from the mom. It's called a umbilical vein because vein travels back to the heart. Again, the one umbilical vein, which is oxygenated, travels to the fetal liver and becomes the ductus venosus, which then will join with the inferior vena cava here drawn in blue. The inferior vena cava in blue here is blue because it contains deoxygenated blood from the fetal circulation. The inferior vena cava that is about to enter the right side of the fetal heart now will contain partly oxygenated blood and partly deoxygenated blood. And so this blood will enter the right atrium and then either go into the right ventricle or it will go through the patent foramen ovale into the left atrium, bypassing the lungs. And then it will enter the left ventricle, which then will be, the blood will be pumped into the aorta and into circulation. The blood that is pumped from the right ventricle can also go through the pulmonary artery and enter the lungs, or mainly it can bypass the lungs and just go straight into the aorta via the patent ductus arteriosus. Okay, so now you have partly oxygenated blood in the aorta, where it will now be delivered to the fetal tissue. The fetus needs oxygenated blood. Once the oxygenated blood is used by the tissue, blood will then normally return back to the heart via the veins. So here the veins are in blue, which indicates deoxygenated blood. But in fetal circulation, there are actually umbilical arteries which carry some of this deoxygenated blood back towards the placenta. And there are two umbilical arteries that do this, and they again contain deoxygenated blood. And their aim is to go to the placenta to reoxygenate the blood via the maternal blood. So let's take a closer look at what happens here.
So there are going to be different types of defects. So there's increased pulmonary blood flow defects, so that's going to include the patent ductus arteriosus, the atrial septal defect, and the ventricular septal defect. This is going to be the most common congenital heart disorder, and this is when there's a communication of some type between the right and left side of the heart. So the increased pressure on the left side of the heart causes some blood to be pushed back to the right side of the heart. And then that increased blood on the right side of the heart is then moved to the lungs. So the one that we will talk about is we'll actually talk about all three of the increased pulmonary blood flow. So first is the patent ductus arteriosus. So remember that the ductus arteriosus is the fetal artery that connects the pulmonary artery to the aorta. So right here. Connects the pulmonary artery to the aorta. Failure of the ductus arteriosus to close. It should close within the first weeks of life. And if it doesn't, then that's going to allow oxygenated blood to shunt from the high pressure aorta to the low pressure pulmonary artery, and that causes the blood to become deoxygenated. So normally you would have deoxygenated blood go from the pulmonary artery to the lungs and become oxygenated, and then you're going to have this oxygenated blood go through the aorta and out to the rest of the body. Well, within the first few weeks of life, you want this ductus arteriosus to close. That way this oxygenated blood is not getting deoxygenated by going back into this pulmonary artery. So the problem here is that this ductus arteriosus did not close. Signs and symptoms: if there is a small opening, it can be asymptomatic. If not, you can have signs and symptoms of heart failure, poor eating, poor growth patterns, fatigue. Might hear a murmur when you're listening to the heart, a widened pulse pressure, and bounding pulses. Treatment for this is indomethacin. This is going to help close that ductus arteriosus, and if it is not working with the indomethacin, they might have to have surgical correction, which is going to include open heart surgery where they clip that ductus arteriosus off. Next is the atrial septal defect. So this is an abnormal opening in the atrial septum that enables oxygenated blood to flow from the higher pressure left atrium to the lower pressure right atrium, causing blood to become deoxygenated. So the atrial septal defect is when the foramen ovale doesn't close. So remember that foramen ovale connects the right atrium to the left atrium. So after birth, that should close. So if you have an atrial septal defect, it is because the foramen ovale did not close after birth. Signs and symptoms: if it is a small opening, then it will be asymptomatic. Other signs and symptoms will be heart failure, frequent respiratory infections, difficulty breathing, or a harsh systolic murmur over the third intercostal space. The treatment is going to be, if it's a small case, it'll be monitoring, but if it is a larger opening, then they will have to have surgical correction, and that requires open heart surgery. Next is the ventricular septal defect, and that's essentially exactly what you think it is. It's going to be an abnormal opening in the interventricular septum. So there's an opening between the right ventricle and the left ventricle. You can see the opening right here. This is going to result in oxygenated blood from the higher pressure left ventricle to flow into the deoxygenated part of the right ventricle, so the blood is going to become deoxygenated. It can range from a pin-sized hole to the entire septum being missing. Signs and symptoms are going to be symptoms of heart failure and a loud, harsh systolic murmur and a palpable thrill. Treatment: about 50% of these septal defects are going to close spontaneously, but if it remains open, then they will need open heart surgery to correct it. There's also pulmonary artery banding, and this is a palliative procedure. Basically, it impedes the blood flow from the right ventricle to the pulmonary circulation, and that helps reduce the pulmonary congestion that can occur. Next, we'll move on to defects that decrease pulmonary blood flow, so we will talk about Tetralogy of Fallot. So in these, there's some type of obstruction of blood flow to the lungs, or if there is no connection between the right side of the heart and the lungs. This includes pulmonary stenosis, pulmonary atresia, and Tetralogy of Fallot. And again, we're only going to talk about the Tetralogy of Fallot. It is the most common, and it also includes pulmonary stenosis and pulmonary atresia. So, Tetralogy of Fallot, it is a combination of 4 defects. So the first one is pulmonary stenosis. So you can see here, pulmonary stenosis, that is when the pulmonary artery is narrowed or stenosed. You have a ventricular septal defect, which we just talked about. So there is an opening between the right ventricle and the left ventricle that allows for blood to mix. Then you have right ventricular hypertrophy. So that is the thickening of the myocardium of the right ventricle. That decreases the force of contractility. And then you have an overriding aorta, and you can see that here. And basically that is when the aorta is positioned directly over a ventricular septal defect instead of over the left ventricle. So it's more so closer to this defect rather than right over that left ventricle. And basically it results in the aorta receiving some blood from the right ventricle, and that causes a mix of deoxygenated and oxygenated blood. Signs and symptoms, you are going to have a baby that is cyanotic at birth, and they will experience acute episodes of severe cyanosis and hypoxia, and these are known as blue spells. As the child is older, they might have a systolic ejection murmur, clubbing of the nail beds because that is long-term hypoxia, dyspnea, squatting, meaning they squat down to breathe, poor growth, mental slowness, syncope, and possibly stroke. A treatment for this is the Blalock-Taussig shunt. Basically, this is an artificial connection between the pulmonary artery and the aorta, and this redirects blood flow back to the lungs to allow for oxygenation. That can also be the complete surgical correction, so closure of the ventricular septal defect, pulmonary valvotomy, which means opening that stenosed pulmonary artery, and repair of the overriding aorta. Next, we'll talk about defects causing mixed blood flow. So mixing of oxygenated and unoxygenated blood in the heart or the great vessels. We will specifically talk about the transposition of the great vessels, but there's also truncus arteriosus and hypoplastic left heart syndrome. Transposition of the great vessels. This is when the pulmonary artery arises from the left ventricle and the aorta arises from the right ventricle. So these great arteries are switched. So instead of the right ventricle going into the pulmonary artery like normal, so normal blood flow is the right ventricle goes to the pulmonary artery. In this transposition of the great vessels, this right ventricle flows into the aorta, and then all of that deoxygenated blood is going to be going to the body, which is not going to be helpful. And then normal left ventricle flows into the aorta with oxygenated blood, but in this transposition, the left ventricle is attached to the pulmonary artery, so this oxygenated blood is going back to the lungs to get oxygenated, which it's already oxygenated, so it's kind of a useless circle. Signs and symptoms are going to be profound cyanosis and also cardiomegaly. Treatment is going to include a palliative procedure. So basically they enlarge the atrial septal defect, or they will create one. Or they can have a complete correction, which is including open heart surgery and switching the vessels to the proper placement. The last type of defect we'll talk about is defects including the obstruction to the systemic blood flow. So we'll specifically talk about coarctation of the aorta. But this is the inability of the blood to reach the body from the heart, so the blood is going to back up into the lungs. This includes aortic stenosis, pulmonary stenosis, and coarctation of the aorta. So what happens in coarctation of the aorta is the aorta, which is when the oxygenated blood flows to the rest of the body. There is an indentation or coarctation in that aorta, and it impedes oxygenated blood flowing to the body. Signs and symptoms are going to be blood pressure in the arms are going to be 20 millimeters mercury higher than in the legs, because that increased pressure proximal to the defect, so closer to the defect, the head and upper extremities, there's going to be more pressure, whereas it's going to be decreased pressure distal to the defect, so in the body and lower extremities. Bounding pulses in the lower extremities, signs of heart failure, and leg cramping on exertion, and they might also have epistaxis. Treatment is going to be removal of the narrow portion of the aorta with anastomosis or a graft. So that is all I have for congenital heart disorders. If you guys have any questions, feel free to email me, bring them to the Q&A, message me on Teams, any way that you can get a hold of me.